Okay, good evening, everybody. We've just come past 6:30, so I might look to start tonight's education session. So thank you to those who have joined us here in the room, and welcome to those who have joined us online as well by live broadcast. Tonight's education workshop is focused on carrying the weight of mental health. We have a number of presenters here tonight who will be presenting on this topic. And before we do, I would like to acknowledge and thank the Office of the Chief Psychiatrist and Adelaide PHN for their support and funding for making tonight's education workshop possible. So before we start, I would like to commence with an acknowledgement to country. We would like to acknowledge the traditional owners of the land that we meet on today. We pay respect to the elders, past, present and emerging, and acknowledge the important role that Aboriginal and Torres Strait Islander people continue to play within our communities. So just a couple housekeeping points. We really would love to keep tonight's education session interactive. There will be an extended Q&A at the end of the presentations. So those in the room, please hold your questions to the end. Those online, feel free to type them in the Q&A as we go tonight, and we will be addressing them in the Q&A session at the end. There is an evaluation on the tables for those in the room, and those online, the evaluation will automatically pop up on screen upon exiting tonight's Zoom. For the GPs in the group who are RACGP and ACRA members, your points will be automatically allocated within the week. And for everyone, you will also receive a CPD certificate to claim your CPD hours or points with your CPD home. And for those in the room, please, we ask that you keep your mobile phones on silent. Anyone needing the bathroom is just through that back door and you'll see the signs. And so would like to introduce tonight's presenters. We have a number of panel members and presenters tonight. So first we have Dr. Teresa Girolamo and Dr. Zana Murfitt, who are bariatric general practitioners. We've got Dr. Kate Hewen, who is a consultant psychiatrist with Carlin, and Karen Haywood, who's a nurse consultant at the Weight Management Service at Flinders Medical Centre. We also have Rosemary Allen, who's a clinical pharmacist with Dartis, Sydney Vanderzelm, who is an accredited exercise physiologist, Joe Hartley, who's an accredited practicing dietitian, and also Michelle Quirk, who is a lived experience member on our panel and also works as a community rehab worker. So fantastic lineup tonight. And so without any further delay, I would like to now hand over to Michelle to lead tonight's, kick off tonight's workshop. Thank you.
Well, hello. As you already know, my name is Michelle. I've been prescribed the antipsychotic clozapine now for around 30 years. This medication has been extremely beneficial in helping me recover from my diagnosis, paranoid schizophrenia. However, being placed on clozapine, I proceeded to put on around 40 kilos, and this really affected my already low self-esteem. Having said that, although I know that there is a potentiality for putting on weight with clozapine, and I know that this is a major deterrent for many patients that are offered the medication, I have to say that clozapine saved me. Currently, I work at the Trevor Parry Centre in Noarlunga. This is a community rehab centre and focuses on skill development for its consumers. I can unequivocally state that I would not be working or indeed functioning as well if I had not been placed on clozapine. So therefore, the question needs to be raised: what is more important, your mental state or your physical health? I'm sure that this is a continual dilemma for the individuals that are caring for consumers with mental illness. Many of the consumers I've worked with have refused clozapine because of their past experiences of weight gain. But for me, it helped me reach a level of wellness, which then saw me lose the initial weight that I had gained. Currently, the medication metformin is being prescribed quite often with clozapine. I have been placed on metformin after having a high glucose reading when I completed my clozapine fasting bloods. The medication has helped me reduce more weight from my body. but you almost should consider that you're putting another substance into your body. There came a point when my weight became too much for me. My parents kindly, when I expressed a desire to lose weight, paid for me to join a women's weight loss gym, Healthy Inspirations. I know that I was truly lucky and blessed that my family was in the position to do this for me, but it helped me immensely because the coaches at the gym taught me about eating healthily and exercise. Getting fitter and losing weight increased my confidence and restored my self-esteem immensely. I also felt that I had been successful at achieving something significant. This all combined to aid me to move further on with my recovery. I'm still recovering. I cannot highlight enough the power of looking after your physical health in its influence and assistance with your mental health. It was extremely hard to begin to move. I was meant to walk for half an hour a day, but initially I could only manage 5 minutes, and my lovely parents walked these steps alongside of me. They continued to do this until I became fitter. As a couple of years went by, it took me this long to lose the 40 kilos. I began to incorporate other exercise that I enjoyed into my routine. For example, I purchased a push bike, and every night after dinner would go for a ride. Yoga became an amazing source of stress relief. It taught me to relax mentally as well. Due to the fact that I hear voices, meditation does not work for me. But yoga focuses on concentrating on your breathing, which I found easier to do. One of the things that I recommend for individuals commencing on medication that can affect your weight is that you begin to eat a little healthier. Because if you continue to eat the way that you usually do, they're most likely to gain weight. Not every individual does when they are placed on medication, but some do, and often it can be a significant weight gain. It is difficult to exercise at first when placed on medication. There is a kind of transitional stage where you must adjust to things like lethargy and changes to mood and sleep patterns, etc. For me, feeling lethargic very much affected my ability to exercise. It was a massive effort to move, but I had to, because it was only by getting fitter that I managed to overcome the lethargy, and that in turn assisted with my overall health, including my weight. It was also a good combatant against the lethargy. Getting fitter meant that I did not feel the oppression of this side effect of my medication as significantly. There are obviously other reasons that people turn to food for comfort other than mental illness. It is everywhere. It's at family celebrations, and we often use it to reward ourselves. Food can cheer one up when they're feeling down. With fast food being as cheap and as affordable, it is an easy option if one cannot be bothered shopping or cooking. It is becoming more and more easily available. The television has so many commercials reminding us of the food available in society. This also impacts on impressionable individuals. Life with mental illness can be mundane. If you're not able to be employed or have something to keep you entertained, this contributes to individuals seeking out ways to keep themselves both occupied and satisfied. Quite often, that will involve eating something which is sweet or salty. Eating provides something to be excited about and brings joy. Currently, there is more of a focus on and a push to respect more the physical health of mentally ill individuals within the mental health system. This is brilliant because it makes services more accessible to individuals. For their clinicians and support workers, it means connecting them with services which will benefit their overall health instead of separating their mental health from their physical health. This could mean supporting individuals to attend the gym or getting them to see a dietitian. Often individuals with mental health will need support to organise these things. Treatment teams beginning to focus on these aspects more will, I believe, be extremely beneficial to an individual's overall health, compromising both their mental health and their physical health together. It is my belief that it's extremely condescending to state that people that are overweight and have a mental illness are lazy. Life with a mental illness is a huge challenge, and exercising amongst others in the community can be as extremely confronting. If this new focus from the mental health system on the importance of physical health continues, I hope that mental health workers will guide, support, and encourage individuals to maintain a healthier lifestyle by accompanying and researching different aspects of an individual's existence and finding means which suit them in their weight loss and physical well-being. Once again, I cannot understate what an immense difference getting physically fit had on my own mental health and life. Without funding such as an NDIS package, individuals on Centrelink benefits are not able to access services like the general public. Paying for a gymnasium membership is hard enough when one is employed in the community. Clothing and other equipment is all out of many consumers' reach. The ability to purchase certain health foods and supplements is also too expensive. In the community, there has developed free means of being able to exercise. There are services out there that can be accessed by individuals, such as the Saturday fun runs that have been taking over the city. Accompanying and supporting individuals to participate in these community events is extremely important, as they often will require support in this kind of social situation. I would just like to say thank you for listening to my opinion about weight and its significance for those with a mental illness. There are certain challenges that need to be recognised when the subject of carrying extra weight is discussed combined with mental illness. I know that many of you listening work with individuals that have a mental illness. I hope you encourage and continue to suggest and support the importance of losing weight and becoming physically fit to these individuals. Thank you so very much for your attention today.
Thank you, Michelle. That was very powerful and very brave of you as well to share that with us. So thank you. And I think it's a beautiful segue to all of our speakers tonight, because all of the points you've touched on are going to be addressed in a little bit more detail. So thank you so much. And I think it really clearly shows that integrated healthcare that is needed in this setting and how the patient needs to be the centre of our focus. So the outline of what, my name is Dr. Teresa Girolamo and I'm a bariatric GP working at REU Health. Outline for this evening, both Sana and I are going to be speaking, and we're going to touch on the relationship between mental health and obesity, weight bias and weight stigma, which we all need to have an understanding of. Obesity is a multifactorial disease, and then I'm going to hand over to Sana to talk about the hormonal regulation of energy balance. We'll look at the assessment and staging of obesity, and rather than talking about comorbidities, we actually talk about complications related to the obesity. And then I'll briefly touch on the evidence-based treatments options, because a lot of these will be elaborated on more by some of our other speakers. So I guess I'm here to set the scene a bit. So I've got 4 points here in terms of the relationship between mental health and obesity. And again, these will all be discussed a bit further, but the bidirectional nature, you know, the chicken or the egg. Medication-induced weight gain, and we'll certainly have Rosemary Allen talking a bit more about that. The strong association that we now know between ADHD, neurodiversity and binge eating disorder, and we'll have Kate talking a little bit more about that. And also the high incidence of atypical anorexia nervosa, eating disorders in those living in larger bodies. So I'm going to start off with talking a bit more about weight bias and weight stigma. What is it? So weight bias refers to the negative ideologies associated with obesity. Weight stigma refers to the discriminatory acts and ideologies targeted towards individuals because of their weight and size. So the comment I think Michelle made about, you know, being viewed as lazy. being viewed as not wanting to help yourself. Weight stigma is a result of weight bias, and we have to very much, as healthcare providers, identify our own personal internal biases. Healthcare, unfortunately, is one of the most common contexts where weight stigmatisation occurs. And this can have very negative consequences on patients receiving treatment or coming for treatment for health because of the way they believe they're going to be perceived. That statement, just eat less and exercise more. No, that's not correct. So let's talk a bit about obesity as a multifactorial disease. And I'm pretty much going to bring all the speakers into this. So if we look on the left-hand side, nutrition and physical activity, lifestyle, sleep, we're going to have a dietitian and an exercise physiologist elaborating more on this. And I think it's really important to understand that no matter what treatment options we discuss with patients, lifestyle factors are always the cornerstone to whatever we're going to discuss. And I think, again, Michelle highlighted the importance of exercise, not so much for weight loss, but actually for general health and wellness, both physical and mental. Up the top, we've got genetics, and there's even epigenetics. So it's the way, in a developing embryo and fetus, the way that genetics are expressed depending on the maternal lifestyles as well. And that can change, and also in the first sort of 2 years of a baby's life. Medications, we're going to have Rosemary Allen talking a little bit more about that, because when we're talking about mental health, we know that there's a number of medications that can contribute to weight gain. On the opposite side of medications, we've got medical conditions. And again, a number of the psychiatric conditions, the mental health conditions, there's that bidirectional nature. Our environment down the bottom. Our environment, we're no longer hunters and gatherers. We've got very easy access to highly processed foods, and our genetics kind of haven't caught up with modern day society, so we are struggling with that. But I'm going to hand over to Zana to talk about our endocrine system, so the hormones that we produce in the periphery of our body and how they act centrally in the nervous system and primarily the brain. And she's going to really stress how important the brain is in all of this.
Thanks, Teresa. So I'm Zana Murfitt, a GP primarily working in weight management. So I'm going to bring all of this diagram up. It looks rather scary, but I don't want you to actually read it. I actually really want you just to listen to what I'm saying, because it's actually quite a simple concept. So for those of you at home, I'm going to try and use the mouse so you know what I'm talking about. But this is really talking about how our hormones control our desire to eat. So So on this side here, we've got the food that we eat, that we consume. So that's made up of carbohydrates, fats and protein. They go into the stomach and our intestine. And as part of that process, depending on what the makeup of the food is, our stomach and other organs will produce various hormones. And you don't really need to know what they are. There is one major hunger, or only one hunger hormone called ghrelin. And when that's in higher levels in our body, we will feel hungry and we will eat. There's a whole lot of other hormones called satiety hormones, and they are hormones that make us feel full. And there's about 15 different types of those now. And so with those signals there that are produced when we eat, there's other signals as well that are produced by the organs in our periphery, and they signal to the brain to tell us about the nutritional state of the body. So we've got adipose tissue or fat tissue, and we've got our liver and our pancreas and our stomach. And with all of those hormones, they are feeding back to the level of the brain to actually tell us whether we're hungry or not. So then we've got this brain area, and the main area that these hormones act is the hypothalamus. So think of the hypothalamus as a control center. So all of those hormones are feeding back to the brain, and it's the level of those hormones that actually is what drives us to eat. But that's not the whole story. So we've got two other areas of the brain. You can see the reward system just here. And that is what I call the eating for pleasure center, because we all like different types of foods. And then we've got the prefrontal cortex just here. And that is our decision-making center. So the decision to eat, just because it's there and we might want it. So this goes, forget that GLP-1 little bit that's on the slide there, that's a mistake. So there's three areas in the brain. So we talked about the homeostatic eating center, or the hypothalamus, where all those hormones are actually being integrated to tell us whether we're hungry or not. Then the area over here, the hedonic eating area, or the addiction center. So we only really get addicted to certain types of foods, right? And they either have fat, sugar, or salt in them, because no one gets addicted to broccoli. I like it, but I'm not addicted to it. I wouldn't get in my car at 10 p.m. and drive to get broccoli, but I might chocolate. And so for some of us, we prefer sweet foods, and for others it's savoury. And so that area of the brain is really active, and in some people it actually overrides that centre, the hypothalamus, where the hormones are actually telling us to eat or not. And then we've got the executive function center, and that is that prefrontal cortex, and that is the area that is just telling us that we might want to eat. So Teresa might bring some cupcakes in to work, and I might have just eaten lunch, but I like the look of them, so I might eat it anyway. So that's our conscious decision to eat. And those two areas of the brain can actually override anything the hormones are telling us. This is a picture that Teresa and I use in our practice all the time, and it's a really useful one to describe to our patients about how hunger and satiety are controlled. And it's basically exactly the same thing that I've just said, just showing that where those hormones act. And it's a really nice thing to be able to tell people, to say, look, the reason that you might be carrying excess weight is not just because you're lazy. It's not just because you don't exercise. It's a malfunction in the way those hormones are signaling to the brain. That's part of the reason. And we also know that medications can interfere with these signaling pathways. So why is it so hard to keep weight off? So I don't know, everyone's probably tried to lose weight at some point in their life. So what actually happens is a bit backwards, really. So when we lose weight, and it doesn't matter how we do that, our hunger hormone ghrelin goes up, makes us more hungry. And those hormones, the satiety hormones that make us feel full, go down. So we've done all this work to lose weight, and we feel more hungry, less satisfied when we eat the same amount of food. So then that drives us to eat more, and it puts that equation towards the right, so that we end up regaining that weight back. And we don't only usually regain the weight that we lost, we regain more usually. I have a favourite saying, fat comes back with friends, and it does. So we don't just regain the weight we lost, we gain a little bit more. And so this is also useful to be able to explain to our patients in that it's not your fault that the weight has come back. Our bodies are biologically designed to do that. It's a bit of a major design flaw. So now I'm going to talk briefly about assessing obesity. How do we assess it? So there's a staging system called EOS. A very smart man called Arya Sharma, who Teresa and I have had the pleasure of meeting, created this scale, and it really puts things in perspective. So there's 5 stages. And it looks at, the medical, the mental, and the functional state of our bodies. So stage 0 would be that there's none of those things present. Stage 1 would be that they're mild. So for example, it might be mild arthritis that's being impacted. Stage 2 is when we've got sort of what we call moderate disease. So things like osteoarthritis might be a little bit worse. We might have pre-diabetes. Our mental health might not be as good because we've gained weight and we don't feel good about ourselves. And then we move on to stage 3, which is severe disease, and then stage 4, end stage disease. So that would be things like liver fibrosis, which has been caused by weight. So we can grade weight like that. The final one for me is just another chart, Teresa and I put together, which helps us explain the degrees of weight to our patients. And it looks at the treatment options. So I've got lifestyle and very low calorie diets there. Now, I'm not saying they're an amazing option to help us lose weight, but I just want to emphasize that lifestyle. So what we eat and the exercise that we do is important and is the foundation of everything we do. But to try and lose weight and keep it off just with lifestyle alone is actually very, very, very difficult. So that's why we now have other options. So we have medication, and I won't talk at all about that because we're going to hear about those from some of our other presenters. We do have some intragastric balloons we can use for those that are moderately overweight. And then once people have a BMI of about 35 or more, then those patients are eligible for some forms of bariatric surgery. And I know that's not the topic of conversation tonight, but it just goes to show how many different eligible options that our patients have at the moment. So I'm going to hand back to Teresa, who's going to talk about some medications.
Thanks, Anna. Oops. Not quite sure what I've done there. All right, we're okay. Thank you. So this sort of continuum, I guess, shows us the overall treatment options and also gives us an idea of the amount of weight loss on average that we can expect with the different treatment options. So you can see we start with diet, exercise, or maybe very low energy diets, and people can lose about 3 to 5% of their body weight. And this is on average. It's a bell-shaped curve. There are always some super responders and some who are not going to respond. So about 3 to 5%. But I guess, depressing statistic is that about 95% will put it back on. And Anna's explained why that happens, the biology of our bodies. Then we've got the first generation anti-obesity medication. I don't actually like that terminology, anti-obesity medication, but the first generation medications that we have traditionally used for weight management, which, sort of provided that 5 to 10% body weight loss. We're now very lucky that we have second and third generation medications, and we're looking double-digit weight loss, percentage of total body weight loss, and the newest one that can achieve above 20%, so 22% weight loss, which I'll talk about in a minute. The intragastric balloons, we're looking at about 10 to 5% body weight loss. That's the IGBs. Lap band, we really don't see gastric bands being inserted anymore, but we certainly have a lot of people living with gastric bands, some maybe not living with gastric bands because they're very dysfunctional in their eating patterns, and they really need to be sent to a bariatric clinic, those patients, to have their lap band looked at. So, that was sort of about 15 to 20% body weight loss. They were very popular sort of 10 to 15, 20 years ago. And as I said, they're really not being inserted anymore because of potential longer-term complications with them. Then we've got the two most common types of bariatric surgery in Australia are the sleeve gastrectomy and the gastric bypass. And on average, we're looking at around that 30% body weight loss. But again, it is a bell-shaped curve, and we can see anything from 15% to 45%, but 25 to 30% we often sort of say is the average. And that's based on data from the Bariatric Surgery Registry that is released every 2 years. And that's data from both Australia and New Zealand. And then SADI and others, they're slightly more complex operations that really aren't being performed very often because there's a lot of malabsorption that can happen with those. So I'm actually going to focus on the medications today. So we've got 5 medications that are currently available, well, actually approved in Australia for weight management. They're not all available just yet. So phentermine, most of us would know about. It is an appetite suppressant that acts centrally. Often it would be a bit of a contraindication in some of our patients with various mental health conditions. Tachycardia, hypertension, insomnia, and dry mouth are amongst the side effects, and often it can be limited by the side effects that people experience, but for some people it can still be an effective medication. It's an oral medication, and on average we're looking at about 5 to 6% body weight loss. And again, when I refer to that, that's total body weight loss, percentage of total body weight loss. We've got orlistat, and that reduces fat absorption in the intestine by about 30%. But unfortunately, this malabsorption of fat is where a lot of the side effects of it come in. And so steatorrhea, flatulence, discharge, even fecal incontinence, and then vitamin deficiencies because of malabsorption. So it's not the most pleasant medication for patients to take. They do need to take it with each meal. And we're looking at very, very modest weight loss with that, as you can see, 2.9 to 3.4%. Then the next three are our newest category. So I guess the phentermine and orlistat have been around for quite some time. Interestingly, before I go on to the next three, I'll just mention that 4 out of those 5 work centrally in the brain. Again, that's how important the brain is. The only one that doesn't is the orlistat, that works in the intestine. So liraglutide 3 milligrams, which is marketed as Saxenda, it acts centrally, again, in the brain to reduce appetite and feelings of hunger. It also slows gastric emptying, so it's kind of keeping the food sitting in the stomach for longer, theoretically keeping people more satisfied between meals. And it increases satiety after eating, so it mimics one of our natural satiety hormones called GLP-1 or glucagon-like peptide that we secrete naturally in our gut after a meal. Most common side effect is nausea / vomiting. I don't really like if people are vomiting on it, but these side effects are usually very transient and settle very quickly, and we do start on a low dose and build up. Change in bowels, but it can be either constipation or diarrhea, headaches, and the rare side effects are gallstones, which is also always a higher risk when people are losing weight, and acute pancreatitis, and a lot of that is gallstone pancreatitis. It is an injectable medication. It's a subcutaneous injection, and it's a daily injection. We're looking on average about 8% body weight loss. So you can see we're starting to increase in those percentages, and patients who respond to it on average lose 11.2%. Responder is defined as a patient who loses at least 5% of their body weight after being on the medication for 16 weeks. So we're starting to get the double digits now. Semaglutide is also in that same category as liraglutide. It is a GLP-1 receptor agonist, so glucagon-like peptide receptor agonist. So it's one of our satiety hormones. That's where it's acting. It's mimicking the action of the satiety hormone. Semaglutide 2.4 milligrams is called Wegovy. It has been approved in Australia for nearly 2 years now for weight management, but it hasn't actually physically come into the country. Semaglutide 1 milligram is the wonder drug on the media anyway, which is Ozempic, and I'm sure everyone's heard about it. So let's not confuse these two. Ozempic, or 1 milligram semaglutide, has been approved in Australia for management of poorly controlled type 2 diabetes. It's not approved for weight management in Australia, but the higher dose is, and we're hoping that will be in soon. And I think that's been a double-edged sword. I think one part of the media, it's actually highlighted the fact that obesity is a chronic health condition, and we have treatments for it that are very effective. But it has also, I think, increased the stigma at times because patients are going to get their script filled and are being very much scrutinised at the pharmacies. So that's been really challenging. It acts in the same way as liraglutide, same sort of side effects. It's a weekly subcutaneous injection rather than a daily. And here we're starting to look at, again, higher 15% body weight loss. And then lastly, we've got naltrexone bupropion, which is also called Contrave, and it acts on two areas of the brain to both reduce hunger and in particular control cravings. You may be familiar with naltrexone, has traditionally been used in alcohol and opioid addiction, and bupropion in smoking cessation. So nausea, vomiting, constipation, headaches, dizziness, and insomnia and dry mouth. It's an oral medication, and we're looking at about 6.1% body weight loss on average, but in responders, about 11.3%. There are some others that I'm just briefly going to touch on, and this, I guess, what we call off-label medication. Metformin's we're going to delve into a little bit more. We do use it for patients with polycystic ovarian syndrome, and we'll hear from Rose about the data in using it with to potentially prevent or minimise the weight gain that can happen with antipsychotics. Topiramate, which in Australia is used to manage epilepsy and also migraine prophylaxis, in combination with phentermine. Now, this combination is not available in Australia. It's available in America. It's called Qsymia, and it's a fixed dose combination of those two drugs combined. It can actually be very effective, and we can potentially use the two drugs separately. Semaglutide, 1 milligram, which is Ozempic. I've already mentioned that, and that is approved in Australia for management of type 2 diabetes. And lastly, tirzepatide or Mounjaro, which was released in Australia at the end of last year. And it works on activating two centres, so the GIP or gastric inhibitory polypeptide and the GLP-1. So we're looking at sort of it acting on two satiety receptors. It's been TGA approved for type 2 diabetes, but in America, it has also been approved for weight management. So I think some really exciting things that are coming up, and there's even more in the pipeline in the research phase. So we've got what we call triple agonists, which act on 3 different satiety hormone receptors. So in summary, clearly there's a very bidirectional nature between mental health conditions and obesity. We all need to be aware of our own internal bias. We need to, as healthcare providers, understand the hormonal basis of energy balance so that we can help our patients to understand and take away some of that shame and blame that it's not their fault. This is, at the end of the day, obesity, a chronic health condition, just like any other. We're very good at healthcare providers in managing chronic health. We're not very good at managing weight and obesity. And lastly, there are now many evidence-based treatment options. So rather than just telling a patient they need to lose weight, we've actually got something to offer them. Mental health conditions do not preclude us from offering treatments, and that includes surgery as well, bariatric surgery, but really importantly, multidisciplinary support is very much needed in this context. Thank you.
Hello, everyone. My name's Kate Howden. I'm actually not with the Southern Adelaide Local Health Network anymore. I did work at Flinders Medical Centre for almost 40 years. Part of that was in the eating disorders unit, treating anorexia nervosa and bulimia, not obesity as such. I now work part-time in private and part-time for our training committee, training psychiatrists. Sorry, wrong one. This. Okay. So I would like to thank Michelle for her presentation. Particularly, she really brought to life some of the difficulties that people with psychiatric conditions can face with their weight gain. both the causes and the effects. And Teresa and Zana, fantastic presentation about all the mechanisms involved and the potential treatments. So as has already been foreshadowed, there's a strong association between mood and anxiety disorders and weight disorders in Western populations, at least. I think there haven't really been studies in other populations around the world. So there's a bidirectional association between mood disorders and obesity. And you can see the figures there. And there's also a very high incidence of mood disorders in anorexia nervosa, even higher than with obesity, 42.1%, and with bulimia nervosa, 70.7%, and binge eating disorder, 46.4%. I've got to say, from my clinical experience, those people with bulimia nervosa and anorexia nervosa are predominantly depressed, but I wouldn't diagnose them with depressive disorders. So they end up on antidepressant medications almost without exception. And in my experience, that doesn't really help a lot because the causes of their depression are much more complex than the simple causes that might lead someone to respond to an antidepressant. There aren't many of those, by the way. So this association doesn't mean causality, and there's a multifactorial relationship between obesity and depression. So as I've put on that bottom point, the depression and anxiety symptoms that we see in a lot of people with psychiatric disorders are often caused by developmental factors, particularly childhood trauma and abuse. And unless those are addressed directly, and it's not an easy thing to address, much harder than prescribing a drug, the results are not likely to be very impressive. So I think Michelle has kind of described this much better than I can in a slide. She didn't talk about depression leading to increased appetite and weight gain, but we see that all the time. And in women, there's a very strong association between binge eating and depression and ADHD. I have been already set up to talk about ADHD by Teresa and Zana. I started off seeing people with ADHD somewhat reluctantly and found to my surprise that they responded extremely well to dexamphetamine, probably equally well to methylphenidate. It's just I use dexamphetamine predominantly, and that there was a high prevalence of eating disorders amongst those people, which improved with the treatment with stimulants. So I had some colleagues referring people with anorexia nervosa to see me for an assessment for ADHD. They would be treated with dexamphetamine if they had ADHD, if I thought they had it. And surprisingly, my colleagues said, oh, you know, their anorexia nervosa symptoms are a lot better. So that was something I didn't expect. And I've seen a number of patients now with binge eating disorder and bulimia nervosa. And likewise, they have a very good response to stimulants, not only with the ADHD, but their eating comes under control. The stigmatization of obesity can lead to depression, and that's something that Michelle was talking about, as well as the activity limitations and obesity-related chronic illnesses that might limit people's ability to involve themselves in social and other activities. I've mentioned the third factors such as childhood abuse, and obviously biological factors can determine the existence of obesity and probably other eating disorders as well. So with each individual, it's really important to assess all those factors and address them as you find them. The effects of psychotropic medications on obesity, unfortunately, not a happy story. Michelle talked very powerfully about the effects of clozapine, which is really the bad boy in the room. Although it is extremely effective in treatment-resistant psychoses, it is the worst offender when it comes to causing obesity. Olanzapine is second on the rank, and olanzapine is used widely in psychiatric wards because it has a sedative effect. So it's very effective in the acute situation, but unfortunately too many people get left on olanzapine long term, and that means that they continue to gain weight if they're predisposed to do so. So the low potency first generation antipsychotics are much less used now. In fact, probably not much at all. Rose will probably comment more about that, but I haven't seen many used lately with all the new ones that have come on the market. The best antipsychotics in terms of weight gain are the ones I've listed there. Haloperidol, as I said, that's a first generation antipsychotic. It's not used so much anymore, but that was one of the least offensive in terms of weight gain. The susceptibility to weight gain on antipsychotics varies according to the person's genetic makeup. And of course, we haven't sort of characterized those differences yet, but some people gain weight, some people don't. Antidepressants likewise are less likely to induce obesity, but some of them are very prone to do so, including mirtazapine and paroxetine. Tricyclic antidepressants are much less used now in antidepressant dosages, but any of them can cause weight gain. When the SSRIs were first marketed, I remember very clearly that they were marketed as tablets which were likely to cause weight loss. And over the years, obviously, people have had the opposite experience, some weight gain on SSRIs and SNRIs. Mood stabilizers also can cause weight gain. As I put there, lithium, valproate are the main offenders. Lamotrigine, topiramate less likely to, and carbamazepine. I may leave this, since I'm running out of time, I may leave this more to Rose, the mechanisms of medication-induced weight gain. They have to do with serotonin 2C receptors and histamine 1 receptors. The side effects, obviously dry mouth and sedative effects can counteract attempts to lose weight. Genetic factors are important, and in schizophrenia, the environmental factors can have a very large effect. And management, of course, has been dealt with a lot by Zana and Teresa, but what can I pick out here? Just that in order to respond well to lifestyle counselling, etc., exercise, you probably need a team approach, so a multidisciplinary approach and a motivated patient. So a lot of people don't have those supports around them, and that was something else that Michelle highlighted in her presentation. Metformin has a minor effect, as far as I understand, when it's used as an additive on to an antipsychotic. It's very important that people be switched off olanzapine as soon as possible onto a less weight-gaining antipsychotic. And I would avoid using antidepressants long-term for most people. People get put on antidepressants and left on them without review. They get left on them for years, 20, 30 years, with no indication. And some of those people will gain a lot of weight. Be careful about augmenting with quetiapine or mirtazapine. I mean, quetiapine is used extensively off-label and I think unnecessarily. And of course, it's important to monitor those lipids and weight and blood pressure if you're using psychotropic medication. This has already been covered, so I won't go over it again. I will just say again how impressed I've been with the use of stimulant medication in people with eating disorders and comorbid ADHD. And I'll now hand over to Rosemary.
Thanks, everyone. Yes, and it's a pleasure to be here tonight. And thank you for all to all the speakers before me. You've really set the scene. So it's particularly Michelle as well. I think without your discussion at the beginning, we wouldn't have, you know, a real good context to talk to everyone about. So thank you for that. I come clinical pharmacist with DARTIS, the Drug and Therapeutics Information Service. Some of you may have seen us around. We've been supporting GPs in their practice as well as other health professionals, but I have a particular interest in obesity management and working with a couple of different groups. So that's wonderful for me. So I'd really like to just add on, and Kate, I think you've described everything as far as the antipsychotics and, you know, in the time we have really well, but maybe just perhaps to add on to the discussion around the antipsychotics and the problems with weight gain, that it's not only them that with obesity, I mean, it is a complex condition. Underlying that is really an inflammatory condition. So with that, you could have a lot of chronic pain, and you could have people not only on the antipsychotics or the antidepressants. You might have a person on a gabapentinoid, pregabalin, or could be on an opioid, of course, corticosteroids. So those are also really problematic with weight gain. So, you know, looking at it, a whole of person, how can we help that person get a better life? And I really like the way you've said it's health. It's not really about weight. We're wanting that person to have, you know, a healthier life. So I won't go to any more of those other ones, but maybe just if you're in general practice or if you're in a pharmacy or wherever setting you are, just consider what the medicine is doing. Is the medicine causing weight gain? How can we help this problem? So, you know, if a person needs their antipsychotic or needs their any of their other psychotropics, that's important for their health. That might be the thing, just as Michelle has mentioned, to get them going to the rest of their health, healthy living. What is it? And is there any evidence? Because it's no use doing things that we just think might help. So I'm interested in evidence, and I really want every medicine that we use to stand up for itself and be of value. So there was this study done. It was an observational study, 52-week study. People with mental illness were included, and they had at least 2 risk factors for metabolic syndrome, which, as we know, is one of the big problems with both with people with mental illness as well as on antipsychotics. But these people in this study were on a variety of psychotropics, so not just antipsychotics. Their baseline measures were diet, exercise, and psychological care. And in all of the studies that I've seen, that is always the baseline. People never just give a group of people a medicine. So you always have the diet, exercise, and psychological care. And I've used this term obesity management medicine. It's, well, we, you know, get our tongues around it, whatever's the best way of explaining these medications. How many people do you think adhered to that dietary, that basic lifestyle advice that they were given? And this is a study, so they had support. Think to yourselves, and for those people who are online, it was 9%, and this was a year study, over 12 months, 9% of people. And it's not, again, the stigma of saying, goodness, what were they doing? You know, how could they not even do that for a year? It's really hard. It's hard to do that. Their psychological care was an online session, and everyone did that because they could do that, and they were given time for it. The exercise was 3 sessions of exercise per week, and the diet was they had to include a substitute meal 5 times a week, 5 days a week. So really, yeah, very few were able to do it all. Things got in the way, just was not possible. Even the people who managed to do it for 3 months were only less than 50%. And 30% weren't able to do it at all. So I think that brings into focus the need for the multidisciplinary care that each one of us needs to help people. Why aren't they getting to the bottom of why can people, or what's making it difficult for them? And maybe perhaps from my side, I've got the easy point because I've got the medicine side, and it's really important to be able to offer the best evidence treatment. And if one treatment is not providing the results that we want, we do need to go to the next options, which are, you know, usually lifestyle, go on to medicines, as Teresa pointed out on her slide, and then perhaps even surgery may be necessary. So for these people, there was a variety of different medicines, and they did use some of the combinations. I probably don't have time to mention all of them, but if you see those on the screen, that's what they were. They really pleasingly did have an average weight loss of nearly 12 kilograms. So, you know, I think that, you know, that was echoed by a decrease in BMI, decrease in waist circumference, which we know is important. And you know, better outcomes. Those are the important things: the good glycemic control, better improved levels of depression and anxiety and stress levels, and eating behaviors also improved. Sadly, psychiatric effects were mostly with the topiramate group. Why that was, you know, really maybe just to point out, you know, we still have to be careful and look at side effects. So I've probably covered this already, but, you know, looking at offering the best evidence treatment where we can. I think Kate's mentioned that, and where she mentioned, you know, the augmentation of things that may, you know, always value the treatment. Do they still need their quetiapine? Are we augmenting with those types of medicines that a person may no longer need? Perhaps that's a good thing to switch it. But in this setting, you can have an augmentation or an adjunctive antipsychotic, which is helping you to kind of offset perhaps the clozapine that you need, that perhaps you can use some in a specialist setting, you know, that there's still options. There's always other options for that person to gain the best health that they can. I've looked a little bit more closely. So that was with all psychotropics. I've looked a bit more closely at the antipsychotics, which are the worst offenders. And just to dive into the metformin story a little bit, again, I think I don't have so much time to, but I did want you to see that there were studies and that we're doing it for a reason, that metformin has been considered the drug of choice for the prevention and treatment of antipsychotic-induced weight gain. A number of trials have proved this, but in most cases, it has been very small. In other words, 3 to 4 kilograms of weight loss, but not insignificant, and people will find a difference. Michelle, you know, found that that was really the thing that helped her. And so I think that, you know, it's really individualizing and knowing your patients, knowing the people that we're caring for, so that, you know, they make use of the best available treatment. This Cochrane review, it was interesting. They did find a reduction that was 4 kilograms, but they also looked at other medicines. They looked at H2 receptor blockers. That's the ranitidine and famotidine. which resulted in 1 kilogram weight loss. I don't think that really is clinically significant. When they looked at topiramate, they didn't find any reduction in weight. So, maybe, it's always difficult to know, but it's good that we have a little bit of information. And again, the other studies really resulted in about the same 3 to 4 kilograms loss, but not everybody gets that. 2 minutes left. So I'll have to just quickly mention that with topiramate, this study found a little bit of a difference, but really not a lot. Orlistat, not very popular. And with that contrave, there wasn't a difference. So I think that when we're coming back to it, probably metformin and possibly the GLP-1 receptor agonists would be the best. I wanted just to point out, just in the last 1 minute, a couple of things, and that is really if people are going to have bariatric surgery, and perhaps you have, or someone planning bariatric surgery, just take a moment to think what happens to the oral medicines that they take. So we think of what happens to the food, well, what happens to the medicines? So there could be, with a different stomach volume, different gastric motility, what is the pH is going to be certainly different. There are going to be a lot of changes in a person who's had a sleeve or the bypass or any of the surgeries, really. So, take those into account, and I've got a tiny little, a long list, but if you just really think what's happening, is it, what will it be if you have an effervescent tablet in this tiny stomach? Definitely avoid any potentially medicines potentially damaging the stomach, the gut mucosa. And it could be, we'll avoid anything that's going to cause dumping syndrome. And I'll end on the last point, which my colleague Joe, who's a dietitian, may mention also, is really make sure people remember and are aware, and they may forget that they do need to have lifelong multivitamin and mineral supplementation. I'll acknowledge my wonderful Dartis team. They are we always work together. So Jody does a lot of our writing, Deborah wrote, our director, Joy, Tanya, Tricia, and Brian. So thanks, everyone.
All right. All right. So I will chat a little bit about why exercise is good for mental health, but I will spend most of my time talking about what an EP actually does and how we overcome a lot of the barriers when treating someone with a mental health condition. So obviously we all know that the evidence in regards to exercise is overwhelming, so I won't spend too long on it, but just quickly, here is some of the brief stats on the different mental health conditions. And as you can see, pretty much for every single one, exercise provides some benefit in managing a lot of the common symptoms for each condition. So for depression, it obviously improves mood and things like that. Intense exercise is recommended, but we'll get a little bit into that about patient buy-in a bit later. For anxiety, 3 times a week, working relatively hard can improve symptoms a lot following acute and ongoing exercise. But it has been proven that it's not as effective as medication for anxiety. PTSD, we see a lot of people with this, very effective, helps them with sleeping, memory, all of those sorts of things. ADHD, which is a big one tonight, increases dopamine levels, which helps them improve with focus and things like that. So the longer the intervention, the more the effect. And then obviously with that improved decision-making, we hope it can also assist with like the binge eating and the things like that. So, and then OCD, significant reductions in obsessions and compulsions after each session, and then of course ongoing as well. So we all know exercise is beneficial. It makes us feel good. It pretty much does all the good stuff, which for the population that we're talking about tonight is obviously the goal. Exercise definitely shouldn't be viewed as like a secondary option. It should be in that first line of mental health management alongside all of the other things we're speaking about tonight. And obviously for ourselves and our clients, everyone knows they feel good. And I don't think you've ever talked to someone that hasn't, felt good after past exercise. So I guess our role in the whole thing is that we're not psychologists and we're not psychiatrists. We're part of the ecosystem. So a little analogy that we use is that, like, if mentally we're not in a good space, physically we often deteriorate as well. So our role is to assist that client get physically fit so they're in a position to get the most out of the other treatments that they're having. From the other speakers tonight, we know that there are many components to mental health management, and exercise is just one little part. There are physiological and pharmaceutical reasons for weight gain and how they can lead to sedentary behavior. So I guess our job is how we can counteract some of those changes. If a client is being looked after from a physical standpoint in conjunction with psychological treatment, we'll obviously improve the chance of increasing their motivation, developing routine, weight management, bit of self-belief, all of those sorts of things. So yeah, I guess when someone comes to us, let's just click that one. When someone comes to us, I guess the first thing we do is ask them how they actually came to see us. Where did they come from? A little bit about their story. They don't need to go into all of it if they're not comfortable with that. But yeah, the main thing I want to do is, I guess, find their why. So a lot of our clients have spent years trying to lose weight and for lots of reasons haven't had much success. So if we can find their why, for whether it's like keeping up with their grandkids, getting off the floor, like I don't really care what it is, but that reason for them that getting healthier is important will increase our chances of improved habits and lifestyle for sure. As we know from tonight, just focusing on the scales, we're not going to have a whole lot of success. So when someone's coming in for weight management, we're definitely supporting it and acknowledging it. But a big part of what we do is educating them about the benefits of movement and exercise and all of the other things that are useful, not just weight. So this little graph I show, I don't know how many times a day. It's pretty much different BMI categories and their fitness level on cardiovascular risk, death. So as you can see, even people in a healthy weight range, if they're not fit, their risk of cardiovascular disease is very high. And then vice versa, even if someone is overweight but is really fit, the risk of a whole lot of things is really low. So just showing them little things like that to show them that just getting moving and improving their health, that is more important than the number on the scales. Talking about relapses, it is normal. So I guess we try to have regular appointments so that if they do relapse, we're reducing the risk of reducing the time that relapse is going for. When it comes to assessments, I guess it's continuing that, shifting the focus. Rarely do I just put them on the scale. We'll focus on like a fitness measure, a strength measure, depression, anxiety, like a scale, a questionnaire. And we use the body composition scales a lot, not to look at their fat mass. I don't really focus on that too much, but looking at their muscle mass is like another thing we can track, and using those things as a goal to get them back, not just, like I said, the scales. The next one, barriers. There's a lot. Getting someone to come to an appointment with exercise in the title is obviously a challenge. And then there's obviously things like non-attendance for people that are struggling with their mental health, past experiences of exercise, time, money, like there's so many. Making time to do something they don't like doing. Literally, I could go on for hours about the reasons people don't want to exercise. In regards to overcoming some of these hurdles, you guys can really help with that. If you're a professional that they trust and they're already seeing, and you're suggesting they go see an EP, they know you're not going to send them to someone that's going to make them do something they don't want. So way more likely to come. And then once they come, we're okay. Now, our initial, like I've said before, that first appointment, we're really trying to shift that focus and just trying to educate them on what movement can look like. Our initial goal is to get some self-belief happening, some routine happening. Dropping off is common. So trying to maybe start with some one-on-ones so they're a bit more supported. And we know supervised exercise has a high success rate in this population because all they have to do is get there. They don't have to worry about what they're doing. Like I said, proving that it can be enjoyable. I don't really mind what they do. I don't care if they take up dance classes or I don't know, walking groups, like whatever they enjoy doing, we can work with that. Goal setting, this depends on the client I'm working with. So if I'm working with someone that's potentially got depression, they're not doing anything, I tell them to, between now and when I see them next, do as much as you can, which sounds very like slack and non-specific. But if I tell them to say, I want you to walk 4 times a week, and they think that's possible, and they don't get 4 times a week, they feel like they've failed from the get-go, which for a lot of this population is how they feel a lot of the time. Or if I say, do as much as you can, and they walk twice a week, they come back thinking, you know, I've got to win. So initially setting up those sorts of things, once we get some wins on the board, we can be more specific. But yeah, just try to get them some confidence because it's usually lacking. Goals around developing routine. So focusing on frequency, not intensity. Building self-confidence, getting them in an environment that's sociable. There's so many things we can focus on that are not weight. Little side note, I had a client the other day in like a super dark place. It took us 2 appointments that got changed to telehealth because she couldn't make it. I guess we started to build some rapport. 3rd appointment, she got here. And then I've been seeing her, I think 3 weeks now in the clinic, and like it's part of her week now. And what we do in the gym doesn't really matter, but she's coming. We're getting there. We're not working her super hard yet. We're just trying to get her confidence in movement. She's talking more, like it's just been wonderful. So she's a little win. Ages ago, she got told to walk for half an hour a day, but she couldn't get out of bed. So just like setting the goal. Like I said, there's all those, like I mentioned earlier, there's all the evidence about the amount we need them doing. I rarely tell a client what they need to be doing because, you know, sometimes it's just too hard. So ADHD, it's been mentioned a few times tonight. Dana sort of asked me about how I overcome this. And initially I was like, oh, I didn't really know. But then the more I thought about it, I think these people can get fixated on things. So in a way, leaning into that and setting some real structure in what they're doing, not giving them free rein, and setting some like real limits because we know they can become obsessive. And like I said before, really focusing on behaviors and not the weight so that they don't become focused on it, which leads to all those binge eating and can feed into that. And as I mentioned before, exercising can improve them with their decision making. So if we can get them, oh, I got my 2 minutes. If we can get them doing stuff, like it should hopefully help with that sort of stuff and bringing in a little hurdle for them. So we're saying, because like our drugs of choice, we've got endless access to them these days. There's no barriers. So if they feel like eating, trying to get them to build in a walk. And if they get home and they still feel like eating, well, they might just do it, but it's just a barrier that might hopefully hold them up. Subsequent consults, following up, continuing to focus on, frequency before intensity and making a bit of a longer term plan, whether it's with us in the clinic, joining a gym, joining a walking group, park run, I'm a big fan. There's so many things, so I don't really mind if it's with us or not. Obviously, finances has been mentioned a few times. Trying to find something that people can do ongoing if they can't continue to like pay for our services. And then when they do progress to independent exercise, which is the goal, trying to still keep them accountable so that those drop-offs don't happen if they do have a little relapse. And then one thing I did really want to bang on about is EPs work in a lot of varied environments. So some EPs work out of like your 24-hour commercial gyms, which for a lot of the population we're speaking about can be a really big barrier to exercise, poor past experience, self-conscious, like lots of reasons. This is a bit of a plug for AEP, but there's other EPs that also work in clinics like ours where it's a private clinic. The only people coming are people that have been sent from their doctors, and things like that. So there's no mirrors, no one's bodybuilding, like it's all no protein shakes, like it's a very comfortable environment. So just being mindful of if you are suggesting someone to see an EP where they actually work can make a big difference. Supervised sessions as well can obviously get people communicating and talking, which is really good. Sorry, I've gone over my time. Ongoing, obviously, we just keep adjusting things as we need. That's how to get EP, how to get there. Your care plans, which is your 5 Medicare sessions per year, we still bulk bill. not many places do. So for people that are struggling a little bit more financially and don't have those funds, they can do that. And if someone's a type 2 diabetic, there's an initial consult and 8 supervised group sessions that they can access as like an extra on top of the other care plan, which is great. Private health, DVA, return to work, NDIS, home care packages, all of those things. So key messages: avoiding the need to lose weight statements, and that they've got to change their lifestyle. Changing the language we are using and setting them up for success and the way we set goals. And then based on tonight, we can see how many like aspects of care are required for these people. And my colleague Sarah rang me and said she uses this quote, so I thought it was good. It takes a village to raise a child, and it takes a team to support the patient. Yeah, done.
For a 2-year period. And I also do support the Carlin bariatric surgical cases as well. So that's me. Let's see if this works. I put the take-home messages up first in case I didn't have time, because I thought I was last and I thought everyone might be asleep by then. So here's an overview, but also the take-home messages. Who's confused? Well, yes, I think everyone can be confused at times. Whoops. No, certainly don't. So we'll go back to my other slide. Yeah. And don't worry, you're not alone. Yes, I'll touch on some food guides. It's always good to do the nuts and bolts of what to eat, but I'll allude to later. It's the how to eat. Obviously, that's what's been touched on as well tonight. So no prizes for anyone to guess. It's not just about what we eat, but how. Also, there's the gut and mental health plethora of research studies that are now abounding in the literature, which are really exciting. And I just love all the new findings in that area. I'll touch on the blue zones. If you don't know what that is, you'll hear about it in a minute. And the Mediterranean style of eating, of course, is the latest and greatest buzzword that's known to mankind. There is hope, though. There's a great landmark study from Victoria back in 2019 called the SMILES trial. And I really do hope that it brings you cheer and joy by the end of the night, because we have been talking about some fairly heavy and serious situations and struggles, and there is hope. Intuitive eating, I'll just touch on as well at the end, marking the note there that it's not suitable for those who aren't eating enough, but that's just another approach to take. I've got lots and lots of resources at the end of the slideshow, and it doesn't mean that I think you don't necessarily have heard of them, but I just put it all together so that if you want to go to it, and also through the slides, I have put the links so that it just makes it super easy if you can just click. I just try and make things as easy as possible. So there we go. Who's confused? Well, you're not alone if you are. On a daily basis, we are given info overload in the area of dietary advice. That's often contradictory and leads to nutrition confusion. And that's not just our clients, but health professionals alike, including myself. The newer terms that are appearing at the moment, ultra-processed foods usually have significant levels of processing and have many added ingredients such as sugar, fat, salt, and artificial colours and preservatives. So they don't actually really resemble the raw ingredients that they're made from. That's pretty much the definition. Inflammaging is a new one. The age-related increase in persistent low-grade inflammation in blood and tissue. So inflammation has been touched on, and it's quite right to do so tonight in this space. And we define pro-inflammatory eating patterns as those that are low in fruits and vegetables, whole grains, and high in commercially baked goods, fried foods, added sugars, red and processed meats. So red meat is actually included there. Versus the anti-inflammatory being high in antioxidants from a combination of fresh, frozen, canned, dried fruit and veg. So they can be at times just good enough and as good as fresh. High eating patterns in healthy unsaturated fatty acids, including monounsaturated and polyunsaturated fats, especially in fish. Then there's the seeds, nuts, plant-based oils, and the high fiber food and prebiotics that promote the growth of beneficial microorganisms in our intestines. So things like onions, leeks, asparagus, garlic, bananas, legumes, the list goes on. So when it comes to, can an apple a day keep the doctor away? Is that true? In part, it can be, but more so if we can just take a look at this beautiful, beautiful slide here of known bioactive pigments that improve or reduce chronic disease. So the rainbow that I'm about to share with you tonight is very colourful. It's full of wonderful pigments, and there's now at least 5,000 known phytonutrients that we're able to access through our food supply. But since we're just pressed for time and I've got 10 minutes, there was one area of research that took my attention about an active ingredient in the yellow spice called turmeric, called curcumin, from a flowering plant of the ginger family. Now, the role of curcumin is linked to helping treat depression. And that was backed up by a 2020 systematic review and meta-analysis of some clinical trials. And most of the people involved had major depressive orders. Now, this was an umbrella review, and it was very interesting. They concluded any benefit in depression may not be all related to the direct anti-inflammatory effect, as curcumin has also been shown to raise levels of brain chemical called brain-derived neurotrophic factor, or BDNF. So it's a key molecule involved in brain neuroplasticity changes related to learning and memory. And BDNF is decreased in people with depression. So curcumin was provided to the study subjects, and after 12 weeks, it elevated their BDNF levels. So it was interesting to know, though, that apart from curcumin, exercise was also a key lifestyle habit that can help with some of the symptoms of depression. So let's just not forget the great talk that we just had prior to me. So rather than everyone just racing out and going and buying capsules of curcumin, which isn't always a good idea if you're on warfarin, but talk to Rosemary later, because that can create havoc. Just talk to people generally about, do you use herbs and spices and the usefulness of them? And, culturally, some people use curcumin a lot more than we Aussies do here, but it's a great thing to try and dip into if you hadn't thought of it before. Let's just quickly, in the time remaining, obviously we've got food guides that are trying to translate the nutritional science in everyday language for people to adopt and follow. There was a survey back in 2019 of GPs and registrars, and that confirmed that 87% frequently or very frequently provided advice on nutrition and physical activity. So this is a great opportunity to then be aware of some of the more recent food guides. Our Australian one is actually very outdated, 2013, compared to the beautiful Canadian one from 2019. But I must say our Australian government is currently undergoing a review of the Australian dietary guidelines, which will underpin our new food guide. So just watch this space. But let's hope that we do take note of what the Canadians have done, a fantastic job. Especially, I love it because it includes social interactions. And that's just impossible. Important people who are living with mental illness to actually be reminded of, are you eating alone? Is there anyone that you can share a meal with? That's something really lovely to do. So I could go into all the facts and figures about how poorly we are in adhering to our Australian dietary guidelines and the food guide here, but that's a little bit depressing. just one figure, I will point out that 1/3 of our total energy intake at the last nutrition survey showed that 35% of our energy is consumed from the discretionary choices in the bottom right corner. So there's a bit of work to do for everyone, and it is a team approach. And we know that these highly marketed, very enticing products that are out there so freely for everyone to buy and consume are displacing the higher quality food groups. So let's not lose hope though. Gut and mental health. This is a favourite topic of mine. On the top left-hand part of the slide, if you can see on the diagram, it lists that a healthy diet rich in phytochemicals provides vitamins, minerals, and one diet that also provides poly and monounsaturated fats and fibre from nuts and seeds and whole grains, reduces oxidative stress, reduces inflammation, improves gut microbiota, and alleviates depression. We know, though, people with depression, and thanks to Michelle for pointing it out to us again tonight, there are so many challenges. The fatigue is quite overwhelming. Sleep disturbances, gut disturbances, lower activity. It's all very difficult. But there are things that can be introduced to improve the gut and mental health of our people that we're dealing with. The blue zones, I'll just have to skip through here if you don't know them. The areas that Dan Butner has studied for over 10 years now in the area where pockets of people are enjoying longevity, and the highest rates of those people are reaching 100 or more. So the Mediterranean style isn't necessarily the most or best diet, but if you want to have an entertaining podcast to listen to on the way home or in the car when you're driving somewhere, pick out this Dr. Tim Crow's really good podcast on Mediterranean style of eating, along with the WHO's diagrammatic example of what is to include for longevity. It's widely known to be an anti-inflammatory diet, but there are other ones as well, also doing a great job. The landmark study, I do want to mention, has other 3 others also listed down there that were RCT trials showing the direct causal effect of not just reducing the symptoms of depression in the study subjects and improving nutrition by providing them more nutrients, but equally there was the added bonus of the anti-inflammatory effect that was noticed, and the well-fed and more diverse gut biota that resulted. So there is a 2-way communication link with the central nervous system, the gut-brain axis that people will have heard about. And it's really important. The diversity of the food intake that we have can lead to a better, healthier gut bacteria. Just finally mentioning not a rigid plan, but an approach. So with intuitive eating, it's crucial to marry the what we eat, as I said before, with the how to eat. And for some people, this approach actually is really helpful. In Salem, we've got the luxury of working in a multi-D team where we have access to psychologists who can really help clients understand what intuitive eating is. And it does help them and assist them to achieve high quality intakes, mindfully eating, intuitively eating, and it's a do no harm approach. There are certain cues that need to be managed in individuals struggling in this area around their appetites and cravings. And these cues can be stimulated by cooking shows or advertisements known as the visual cues, or the emotional cues of states of feeling sad, lonely, stress, and boredom. And there's also cues of just smelling lovely, freshly baked bread, or everyday situations where people are faced with certain social pressures of come and join us in the party tonight and let's have this, this and this to eat. So all of these cues, they mount up. And for individuals, if they learn about an intuitive eating approach, it's just an alternative option that can be quite an effective outcome. And with the bariatric program at Salem, the psychologists are measuring the score of intuitive eating with the clients, and we hope to be looking at the data of not just pre-surgical but post-surgical 2 years follow-up, just to see, first of all, if we've done any harm, but also to check whether the self-rated scores are positively related to body appreciation, to self-esteem, to satisfaction with life at the end of our barrier program. So I just feel really privileged to be working in this space for quite a while and helping people to move towards making small achievable changes. We've talked a lot tonight about making it a stepwise approach or small goals. I believe that that's really paramount, and to not overwhelm clients. I also try creating an environment where they feel safe and are not fearful in the fight, flight, hypervigilant state. And anything that I do see as an improvement is sort of, I come at as a strength-based approach. So really, I do want to encourage you all, when you are in contact with these clients who are on a journey, that you set up an environment for them to feel safe, where they can be able to trust you. And that was a great example of Michelle before, talking about trust. But when it comes to food, if there's any little small, tiny changes where they do have a little bit more fruit and veg, or a bit more grains or nuts or legumes, or even just a splash of extra virgin olive oil onto their food, these can all contribute to making their mental health improved. And that's by reducing low-grade inflammation, reducing oxidation, and enhancing brain plasticity. So I do hope that this talk has sort of just whet the appetite. It's been one of the most challenging talks I've ever had to do in these 35 years of being in dietetics. And I've had 10 years at uni, and it's all very much sort of got more time than what 10 minutes can really deal with in such an important topic. But I've plastered lots and lots of links for you to dive into if you are at all interested. The resources I do want to pick out here, apart from the eating guides, the Canadian one there is great. It's got lots of sensible recipes, but there's also some wonderful recipes on our own South Australian preventative health site that links into the Western Australian Live Lighter recipes. Really easy, you just plonk in, I've got chicken and broccoli tonight, and then up comes sort of recipes that are quite simple. They've got a time on them, how many people it serves, and it's really been created with a budget sort of in mind, a budget friendly. I've also added in here the RAVES eating model. If you are dabbling in the area of eating disorders, that's a nice little pocket book guide to how to develop a positive relationship with food with clients there. Also, there's just so much. Mental Health Coordinating Council have a really lovely link there for recovery orientated language guide of just the language we use. It's really important. And the Weight Issues Network, don't like the title do's and don'ts, it's very prescriptive there, but a simple awareness guide for healthcare professionals. So just click on that and have a little explore, because it's been brought up this evening as well. If you do want to find a dietitian, please go to the Dietitian Australia website. You can plug in the postcode and pops people, but there's also Pod Dietetics at the bottom there, who are very weight neutral service. If you're interested, they operate out of St Maurice, also St Mary's and Port Noarlunga. And also the links for I find in bariatric work, there's a lot of access for anorexics, but there aren't as many options for people with binge eating disorders. So there's just that optional program there. Thank you very much for listening. Sorry, it's such a ramble.
All right, on the lucky last. We're doing well. Thank you for everybody for sticking with us. So my name's Karen. I'm the nurse consultant from the weight management service at GP Plus at Marion. I sit under Flinders Medical Centre and we're part of SAPOM, which is the South Australia. Sorry. Yes, it is. No, it's not. Yes, it is. It's the South Australian. No, it's not. It's the Surgical and Perioperative Medicine of Flinders Medical Centre. Got too many acronyms, clearly. So I'm going to talk to you, shift the pace just a little bit, and I'm going to talk to you about our service, which offers a surgical model for supporting patients with overweight and obesity. We are a purely surgical service. We did used to have some hours for non-surgical. However, now we've obviously been reduced in our hours, so we are purely surgical. And I'm just going to look at the process of what to do for everybody in GP land, essentially, but also to other specialists as well. So we can accept referrals from nurse practitioners, specialists, whoever is interested in referring a patient that they're seeing. You can contact me and, I can help you out. So these are the things we're going to cover off on really quickly. So our service, it was established originally in 2013 to actually support the surgeons who were being overwhelmed by referrals to the centre of patients who needed some support with their obesity and their overweight. We offer a triage and assessment process which determines our eligibility to surgery. We do have eligibility criteria. If you're interested in knowing what the criteria and everything is, Hannah I've emailed her our referral form, so you're most welcome to contact her, or Hannah will email it out to everybody who's indicated their interest, so that you know what the eligibility criteria is. We provide a comprehensive and integrated approach for patients. We are a interdisciplinary service, so we have I'll share with you in a minute. We have a team of people who actually see our patients in a program. We call it a program. It's really a series of appointments, but we support our patients working towards bariatric surgery. We do accept patients from the Southern Adelaide and regional areas, including the Fleurieu Peninsula and Northern Territory. I will just say at the moment, dare I say this out to the wide world, we are the proxy statewide service right now. Don't overwhelm me with your referrals, please. But there's one option left at the moment. We're working on more. So just FYI. Our service team consists of me, the nurse consultant, a physician, clinical psychologist, a dietitian, the exercise physiologist, which my position is currently vacant. If anyone knows of anyone, let me know. And a postdoc dietitian who was Joe, who very kindly talked. And we also have Rose, who's a new addition to the team. Sorry, Rose. Who's our pharmacist. She's very, very important and I love having her. Our referral assessment is currently based on the NIH, and I can't remember the acronym for that one, consensus statement, which was written in 1991. It was a long time ago, but there has been another one recently released in 2022, and I'm currently in the process of reviewing that. However, there won't actually be many changes because one of our surgeons, Dr. Lillian Cow, was involved in setting the service up and was involved in writing the first consensus, and she's also been responsible for reviewing with the team the second release, so it won't really change that much. We do have I do have a triage process as well, which Teresa alluded to earlier, and Zana, about the Edmonton score, obesity score. So I have a triage basis that is based on that. So I do take lots of things into consideration. There's many, many moving parts with the referral. Our eligibility criteria, just very briefly, I'm not going to go through it. It's fairly complex. If patients don't fit any of those things, then I will, decline the referral. I do want to just say, though, one thing is that the mental health, as was indicated and discussed by Teresa earlier, the mental health doesn't preclude people from having weight loss surgery. However, it is imperative that multidisciplinary support is available for those patients, not only in our service, but also in the community, pre-surgery and post-surgery. It's very, very important. And in actual fact, our surgeons will not operate on somebody unless they know that that support is there because of the impact that it has. So it's not, but I will also say too, that it's not the only reason why they should have surgery. So just because they have mental health doesn't mean that they're actually eligible for surgery. It's like with everything. It's very complex. There's lots of moving parts and we're all interrelated. We do have lengthy wait times in our service. This was even before we got to the point of being a proxy statewide service. And currently, unfortunately, I have to tell you that our wait time to come into our program, which is pre-surgery, is around 4 years, possibly longer. The surgical wait time currently is around 18 months to 2 years. And I hate saying that out loud. But we are working obviously every single day. I'm in the wait list every single day to try and fix it and change it and make it faster and all the rest of it. We try to be as fair and equitable as we can. After surgery, we do have our patients come back into our clinic and are seen by our lovely Jo for up to 2 years post-op. And then we will refer them back into the community. And we know that currently it's a little bit, the guidelines or the suggestions of how a GP or specialist manages their patients post-op is not quite as clear as we would like. So that's something that we're working on as well. How am I going? Very quickly. So I haven't talked much about mental health. We do have a clinical psychologist. The support within our team is focused on many things, but essentially it's their body image. It's the food relationship, as Jo's already mentioned. It's the self-management of emotions and behaviours. We all know that food means many things to many people, and it's linking with those community support networks as well. Unfortunately, because of our hours and our resources available to us, we're a 1 day a week clinic where the clinicians come in and see the patients 1 day a week. I'm sitting in the office 5 days a week. We have limited capacity to support the patients with any established mental illness, and we really do rely on the community supports that the patients already have. So established reports with the psychiatrists, with the psychologists, and our clinical psychologists will liaise with all of those specialists. We don't have the capacity to diagnose or treat or manage any new mental health conditions. If someone comes in and there is a new diagnosis, then we will allow them time to go and establish those reports. We know that the time frame to see a community specialist is a long time. We hold the patients in the program. We don't discharge them. We'll bring them back in after a designated amount of time, and then we will review them again or start their program or whatever it might be. We're very individualized. We focus on the patient. We don't just focus on delivering a service, and it's not a cookie cutter approach. And again, if the patient comes through and then gets to referral through to our bariatric surgeons, and surgeons feel that they need more support, we will go back to the GP or specialist and make sure that that's in place and then get the patients back in. The other thing too, I suppose, is really important is that we need the patients to engage. We can do all of this stuff, and there is loads and loads of community support and other supports for people if they will engage. If they engage, and that's obviously the tricky bit, we've got to get over all those barriers which we've been discussing tonight, then the world is their oyster, quite literally, and we are there to support them. But they have to engage. They have to meet us in the middle. Otherwise, we can't do anything for them. What the people can do in the community, so we're talking to GPs and specialists and everybody right now, we want them to support the patients with a timely referral to the community mental health. So just as an aside, part of what I'm doing right now in the service is we're about to sort of put together a whole stack of education for GPs and other community specialists so that they know what we need. So when they refer the patients to us, they're almost ready to come into the program. We're not having to hold them and guide them and send them back and get them to do things. We want the GP or whoever it might be to say, okay, well, we know that you need to do this. We know that you need to do, go and see this person. We want them to provide an alternative amount of avenues to seek assistance. And we've got resource lists, which I know have been put together and will be provided to everybody. And again, as I said, we want to encourage our patients to establish and maintain the support in the community, and it has to be post-op as well. We've talked about this already tonight, and it does sound sometimes a little confronting. As humans, as health professionals, it's already been discussed. We need to be aware of what our own bias and stigma is towards obesity and overweight. Only then can we change the way that it's already being managed and how it's discussed with people. I speak to patients every single day, and the stories I hear, unfortunately, from my own colleagues and peers sometimes are horrific. Please be mindful of the language you use. Do not assume that you know how that person got to this particular spot. Often it is something that is well out of our scope of vision. And only when we actually ask a simple question, such as, what brought you to this point in time? And you stop and listen without judgment, will we actually hear the people? And then we will be able to make the changes. There is lots of mental health supports available. We just need to be able to know and tap into them. You are most welcome to reach out to me and I can send you things via email. This is already in the resources. There are new things popping up every day. We don't expect everybody in the community to know what's going on because they're in their own world, and that's okay. This is what we do. We need to be mindful the patients who we see at Flinders are in a different cohort because they're in the community and the public space rather than the private space. So we're always looking for resources that we can provide to the patients which are going to cost little to no money, or that they can get on a healthcare plan. That's it. That's all I got. Thank you.
Thank you. Now we have a few minutes remaining, so I would like to invite up all of our speakers today. We'll close the session with an open Q&A. So those in the room, if anyone does have any questions, please raise your hand and I will come around and ask that you speak into the microphone. I'm just going to move this. So our panel members, please move up. And when you're answering, if you can please speak into the mic, so those online. Yeah. So those online,
that too. Oh, now I can't see the question. Okay. Oh, yeah, we're reading on the board. Yeah, do you want me to read that? Yep. Yeah. Any questions from the room? Do you want me to answer that one, Helen? Yeah. So in the opinion of our speakers, is there a place for plastic surgery to assist with the physical and mental aspects of obesity? I can just very briefly talk to that from a surgical point of view. So we do have like plastic surgery for skin removal post-operative. However, that doesn't happen for up to 12 months afterwards, because we obviously need to allow time for the patients to lose weight. The other thing to note that, again, we're in the public space and there is a lengthy wait list. So, you know, it's, yeah, another few years down the track, but definitely, but not before weight loss surgery or before weight loss. So I know some patients get referred to us, they want an apronectomy. That's not going to happen in our space before they actually have the weight loss.
Yeah, just thinking about the psychotropics and dopamine pathways and how they also affect the pleasure and reward system in our brains, and how that's also a complicating factor for people trying to make changes in their lives and getting a sense of achievement and reward in what they're doing. So I guess recognising that that's an added challenge. So that's a comment. Just a question then too, with the obesity management medications, the costs of those. I think most of them are outside of the scope for most of the clients that I work with, unless there's going to be some changes in terms of PBS cover.
Yeah, look, you're right. They are very expensive. And I guess in the public space makes a lot of them, I guess, unaffordable. Sometimes Teresa and I like to talk to some of our patients about what it means on a daily basis for some of the cost of these medications. So the costs that are quoted, that you'll read, are actually at the highest dose per month. And we have a lot of patients where we would start them on a very low dose of the medication. So liraglutide, for example, or Saxenda. Yes, it's $387 if you have to buy a prescription, which is ridiculously expensive. However, if we start at a really low dose, so 0.6 milligrams, there are some people that can get a lot of good control back over their eating only with really some of those lower doses. And at 0.6 milligrams, that $387 would last around about 5 months. So if you break that down to a daily cost, it does make it more affordable. But yes, they are expensive for a lot of the population. From a PBS perspective, there is one of the newer medications that we believe will get PBS listing for weight. There will be conditions around that. And so that's a bit of a watch this space. But there will be conditions around it, because if we just opened it up in terms of a big open slather, I mean, everyone would want it, because some of the newer ones are extremely effective. So look, we're hoping to see some change in that space. But yeah, I think using lower doses can sometimes help with the cost.
We do have a second question from online. So it's from Stephen Wu. Any research and advice on how to maintain weight loss after pharmacological or surgical treatment?
I can probably answer that as well. Teresa and I were just in Sydney delivering a 2-day course to healthcare professionals on bariatric surgery. And we now know that weight, or living in a larger body, whatever you want to call it, obesity, is a chronic disease. We know that it's not just purely caused by lack of willpower, and we know that there are many factors involved in that. And we actually now know that even with the use of pharmacotherapy or some of the surgical treatments that are very, very effective, obesity is a lifelong condition. So even though patients will lose usually quite a lot of weight, is it possible for them to gain that back? Absolutely. And we know the reason for that is that hunger can start to come back. We know that people can accommodate more food down the track after bariatric surgery. And we know, just like diabetes, if someone's sugars were to go up and they're on some therapy, we wouldn't say they're a failure. We would say that that's I guess, a progression of their disease, and we would escalate treatment. So even if a patient has a really powerful procedure like a gastric bypass, when their hunger comes back, when they start to weight regain, we would escalate treatment and add in some pharmacotherapy and other things to assist them with their weight. So is it a definitive treatment? The answer is no.
Another couple questions from online from Justin Chong. Can I please ask how you approach the use of semaglutide for weight loss with regard to the dose? Do you increase to 1 milligram as quickly as you can? Also, what about Ozempic up to 2.5 milligram dose? Is that you again?
I can probably do that. Teresa can as well. You probably get sick of hearing me.
Yes. So as I mentioned before, semaglutide has 2 different doses and 2 different brand names. So semaglutide 1 milligram is Ozempic, and that is available in Australia, although it comes in and out of availability. And the recommendations are for management of patients with poorly controlled type 2 diabetes. And the TGA has put recommendations that we limit the prescriptions for that use at the moment until supplies are better. However, semaglutide 2.4 milligrams, which is brand name will be Wegovy, was approved about 1.5 years ago for management of type 2 diabetes in Australia, but we haven't physically seen it come into the country, but we do hope we might have some more information later this year. So I guess when we look at, excuse me, if we are using semaglutide 1 milligram, so Ozempic in someone who has type 2 diabetes, but is also experiencing issues with their weight and obesity, we would start at the 0.25 milligram dose, and we would be monitoring the effect on both glucose management as well as satiety, not weight per se, but are they feeling more satiated? Are they feeling less hungry? Do they feel they've got a bit more control of their eating patterns? And you've probably heard the catchphrase of the food noise, so reducing that food noise so that they can personally make those better choices in that prefrontal cortex of the behavioural change. That's what I use pharmacotherapy for weight management for, not because they're going to do an injection and the weight's going to come off. It's helping them feel they've got a sense of control. So going back to the Ozempic, as I said, in patients with type 2 diabetes, 0.25, the next dose is 5 milligrams and then 1 milligram. At the moment, the 1 milligram, so the higher dose pen is the one that's more readily available. So some people are having to sort of count the number of clicks rather than going straight to the 1 milligram dose, because that can cause a lot of side effects.
I can answer the next question about so-called dependence or addiction to semaglutide and approaching the weaning of the medication. So I want to start with that one. So let's talk about another condition like hypertension, high blood pressure. So if we put a patient that's got hypertension on a blood pressure medication, do we say, let's give that a go for 3 months and then we'll stop it, see what happens to your blood pressure? Blood pressure is going to go up again. Now, when we've got medications as powerful as semaglutide, if we put them on it and it gives the desirable effect, so reducing food noise, better control over eating, just like Teresa was saying, my answer to that is, why the hell would we want to stop that? Because if we stop that, we then stop the effect that it has at the level of the brain, which will then mean the food noise will come back and they won't have as much control. So our answer to any of these medications for any chronic disease would be that if they are working and the patient can afford it and that they have minimal side effects and are tolerating it, then we would continue that medication. So that's my answer to that one.
Give another. I think once somebody has achieved a weight that they're comfortable and happy with, and that's certainly not looking at ideal BMI. BMI is not a great assessment at all of the effects of obesity. We talk about the actual adiposity being the main issue, the unhealthy weight. And so if somebody has achieved a place where they're comfortable, and before we even start treating somebody, we have to actually set the right expectations. So if somebody is hoping to go back to their weight they were when they're 25 and they're now 45 and have had 3 children, and they want to be in that ideal BMI, and they're starting with a BMI of 35, we're setting up unrealistic expectations. So at the start, we need to set those realistic expectations. But once someone's achieved a weight that they're comfortable with, there are times we're able to actually reduce the dose of some of those medications because we're aiming more for maintenance. Or there are times where some people say, look, I'd really like to try and come off them. And I say, that's fine. I'll let them know what the expectations are from the research and from the data that we will start to see some weight escalation, but they'll often give themselves a buffer zone and then they'll say, okay, I know I've got my security blanket and I can go back on them because, as Anna said, we know it's a chronic relapsing remitting disease.
Is that working? Yeah. Thank you so much. I'm not really sure who this is directed at, but I work at the State Prevention Agency, so Preventive Health SA. And I suppose our Minister for Health and Wellbeing, he's within the remit that we're currently working towards, there's a priority around obesity prevention. It's also a priority around mental health and wellbeing. So I suppose we've talked a lot or heard a lot tonight around stigma, weight bias, and I'm wondering what advice any of the speakers have tonight around kind of educating, senior policymakers around, it not being the fault of an individual, and that it's not just about lifestyle factors around food systems and physical activity, although extremely important. Physical activity is my role within the prevention agency, but it's about system change. And so I just was wondering if anyone had any kind of key insights of wisdom that might be helpful.
Yeah, we'll probably answer this with a multiple pronged approach, but this came up in our course that Teresa and I were at in Sydney over the last couple of days. And one of the surgeons got up who is a very experienced bariatric surgeon, and he said, any talk about weight should start with stigma and bias. And he said, if you don't have a talk ready, get one. So basically, any education that we do, whether it be to ministers, patients, colleagues, we need to start with our thoughts and ideologies around the issue of weight to then really look inwards and actually start to understand that so that we can then move forward. It's got to start there. And so there is a lot of research out there at the moment on stigma and bias. And I think any pitch towards any treatments towards obesity has to start at making them maybe understand what their own biases are to begin with. You can probably add to that.
Yeah, I agree, absolutely. And I think if you want, for anybody who wants to just have some basic stuff to read and to hear from a patient's perspective, the Obesity Collective, which is a website, is actually a really good place to go because they are a group, it's an organisation that supports and promotes the community and the individual that is living with obesity and overweight, and they're real people. There is the people on the board or on the committee. Some of them do have lived experience and they're professionals. So I think that's a really good place to start. And I think the other thing too is just being mindful of the words that we use. So there's lots of different words. Like you could go really basic and you go, well, we don't say that anyone's fat anymore. Like now we're carrying extra weight or we're overweight. Now we actually have moved to saying we're people living in larger bodies because we know that it's not just a diet or an exercise issue. Some of it's related to, as Teresa and Zana have already talked about, is genetics and medications and mental health and other comorbidities, which is all tied in. So I guess myself and Joe were talking about on the way in the car here today, as I said at the end of my presentation, just simply ask the patient what brought you to this point today, and just hear them talk about their journey. And that will actually enlighten everybody about how to communicate with people. And if it feels uncomfortable when you're thinking about the question, don't ask it.
So I've got a few comments. One cynical one, social media. Get Oprah to speak to all the politicians. The next one is about the Obesity Collective. So I'm part of the Obesity Collective, and there's also WIN, which is the Weight Issues Network, which is people with the lived experience, and that's incredibly valuable. Also NACOS, which is the National Association for Clinical Obesity Services, which has a multi-pronged approach. It involves people of all disciplines, and I'm on the committee for that as well. So I think they're the two biggest. So Obesity Collective and WIN, which are combined. NACOS also supports WIN. So they're the areas. I think NACOS is more about treatment strategies. Obesity Collective is prevention and treatment. We can't use any one of them alone. You know, we've tried prevention for a long time. We still have to keep going with it, but we have to join and marry the two, you know, and I think that's a really important, because I think in the past we've had people on either side of the camp, and we can't keep doing that.
Sorry, we could talk all day, as you probably have gathered. There is another resource that's not Australian, but I think is extremely powerful, and that is Obesity Canada. Now, they are well ahead of the curve when it comes to obesity management and education. They have some amazing free resources online on stigma and bias, which I know it's Canadian, but I mean, weight is weight, and we are all people. And I think that they have some amazing resources that you could easily get access to by Googling.
Okay, we've got a couple other questions online as well. So there's a question about a patient who's asked to access Ozempic non-PBS for weight loss, but wanting to administer above the 1 milligram approved dose. Any comments on getting this from compounding pharmacies? Rose. Is that Rose? Is that for Rose?
Yeah, this is a difficult situation, because the ability, or you know, for compounding medications is really designed to help people who aren't able to access a medication, which has been the case in this situation, but it's been extended and probably, you know, rather enlarged. And because it's an area where people have had, you know, found a medicine that they might be getting good results with, suddenly not available. Perhaps the answer really is, you know, looking at the compounding. If it is, and I know that there have been some compounded medications that have made their way into people's hands through whichever sources that have been questioned. If it is a reputable compounding pharmacy, then there's that is a compounded medicine, and it will cover all of the requirements. But it is off-label. So if you're prescribing it as such, patients do need to consent to that. They have to know what they're taking, and that it is as you would with any other off-label prescribing. So maybe that's my, you know, one message, and it needs to be used in the appropriate way.
Okay, it's sort of two-pronged. I work in acute community mental health. Given that there's a 4-year wait because you're de facto state thing, is there lobbying going on? Because if you're only open 1 day a week as a clinic, having that service 2 days a week halves that waiting period. And the other thing is, being a 4-year wait, community mental health, we wouldn't keep somebody open that long, not to support them with their wait. Even people with, because community mental health is or the acute stream, we've got very limited time. So the continuing rehab stream, we do have people open for years and years. But even with chronic mental health conditions, the idea is to get them back into primary health care rather than, what we're doing. People with schizophrenia or bipolar or, any of your Axis 1 type things, most of them are not open for 4 years anymore. So what sort of supports where would people go to get that support from your service so that they can then qualify for surgery or whatever it is that's offered after that 4 years?
So just to clarify, are you asking from a mental health perspective of what they
yes.
can do?
Yes.
Okay. So the patients that are referred to us, so this is my practice. When the patients are referred to us and they're eligible for our service, I have a phone call with them and go through a health assessment and provide them with a number of resources that will support them during their wait time. I also send a letter to the GP providing some resources and summarising the conversation that I've had with the patient and requesting that the GP do continue to support them in the way that they would have even prior to actually referring them to our service. So there is also too, as I alluded, there is also too other resources available in the community. So there is a coaching program that we refer all of our patients, well, we encourage all of our patients to contact. We don't actually refer. We do have that ability, but I do believe that the patients need to be accountable and it needs to suit them. So Better Health Coaching for South Australians used to be called Get Healthy. There's a number of allied health professionals that are in that organisation, including psychologists that can actually support the patients. If the patient and I have a conversation about their mental health and they're aware, there's obviously Beyond Blue that can support them. There's, if there's somebody who might have sporadic contact with a psychologist or a psychiatrist, then I provide them with all of the urgent healthcare lines. And then also too, on top of that, I will provide them with the resources that I provided tonight about the online psychological support. So there is a lot of support that we do give them. And I guess the thing is, like you were saying about not having them open for that long, even if they weren't referred to us, they would still need to have that support ongoing for years and years. So it's just about being able to offer them that and to make them aware of those things. Yeah.
Just also, obviously, we're all familiar. Well, firstly, I think the letters back to the GP are crucial because the GP is always going to be that centre of care for working out what the management plans are. I think we're all familiar with the GP mental health care plans, but don't forget the eating disorders care plans where patients can get up to 40 sessions with dietetics and 20 with psychology, and they qualify if they've got binge eating disorder. I mean, there is a big questionnaire that needs to be filled out, but certainly I know that a lot of our patients will qualify. The big thing with that, when you're referring patients to community care or primary care settings, making sure, certainly as GPs, that patient is being referred to somebody, both the psychologist and the dietitians, who have an interest in this area, because there are many who don't. It is quite a specialised area. And if we're not all on the same page and using the same language, we're really not going to get anywhere with those referral processes. So you've got to find your own tribe and your own network of people that you feel confident referring a patient to.
Okay, we've got another couple questions from online. We have gone a bit over, so we might close off with these final two questions. So Stephen Wu has asked, how are we going to afford the costs of these procedures and drugs and consultations with health professionals looking ahead in 10 to 20 years?
So that is a real concern. Our current rate of patients living with overweight or obesity is 67% of our adult population, and our rate of patients living with obesity, so BMI above 30, is 32%, 32%. The projection in the next 10 years from the World Obesity Atlas, which identifies every country, is telling us that it will be around 50% of patients living with obesity. So we need to do something. How we're going to afford it if we don't prioritise the management of weight and obesity, we will be looking at those downstream conditions that it causes. So obesity is a gateway disease. It's going to lead to so many other chronic health conditions. Xana and I are incredibly fortunate that we see it day in, day out, that the lives of these patients is so improved, and we're able to, their chronic health is improved, their mental health is improved, their physical health is improved. So we can't be working in silos and treating each individual health condition, because patients living in a larger body need that to be targeted rather than us throwing more and more medications at them for all their chronic health conditions. The World Health Organization in 2022 said that this is one of the
yet most neglected public health issue.
Most blatantly obvious, yet most neglected public health issue, and we need to prioritise it. That's the World Health Organization. The World Health Organization actually labelled obesity as a chronic disease in 1997. Over the last decade, we've had multiple international organisations, reputable international medical organisations also labelling it as a disease. Unfortunately, in Australia, we haven't. But there is, we're catching up. But there is the Lancet Commission, which should be released later this year. And that's international experts in obesity, around 60 international experts. And they're looking at the definition of clinical obesity. So there are some people who are going to live in a larger body and be healthy. We're talking about the health consequences. So we want to reframe it. It's not actually about obesity. It's about the health consequences it causes. They are looking at renaming it to ABCD, which is adiposity-based chronic disease. Now, I think that's a mouthful, but I think it says this is what we see it as a disease.
If I can just add one thing there, and I totally agree with everything that you've said, Teresa, is that perhaps it's looking to the next generation. And we talked a lot about adults, but in children, that's where we need to start. So I think there have been, with these groups, some calls to action of trying at least to maintain the weight increase in adults, but slowing it down in children. And that is a multi-pronged approach. It's a social problem. It's economic. It's everything. So I think maybe it won't happen overnight. We'll have to work on the younger people as well.
If I could just make a comment about that too, I thoroughly agree with that, aiming at children. And I think as a political move, we should be advocating for a meal at school for every child at school. And if that was a healthy meal and it was right from kindergarten through to high schools, and children were getting that kind of information and that modelling of what a good healthy meal and diet is, that'd be sort of not quite so many children who were starving hungry, but also the message going home to the family.
I totally agree with you, but that's where we can't just target the schools. It's about the environment they're living in. The New South Wales government has got some really good resources on healthy habits for children, but it really starts off with the adults, because they're making those choices, and it's what the children, what environment they're growing up in. So it's both. It's the school education, it's the family. What we often find is that adults who have successfully been achieving some weight loss and changed a lot of their lifestyle, they'll often say to Zana and myself, "Can you see our children?" And that's just heartbreaking, because at the moment we can't. We do see, children from 16, but in the States, liraglutide or Saxenda is actually approved from the age of 12. We don't have that.
One final question, which I think came from Sarah online, was exactly that, about approval for medications in children. So overseas, yes, liraglutide. There are some current trials going on with some of the newer medications, and I'm being privileged to be a part of one of them, which is a trial for tirzepatide or Mounjaro in those from 12 to 18. And I think that's starting in July. So that's a worldwide study, and there's been 5 centres in Australia being chosen for that. And so we're going to be able to incorporate some of our young people in Adelaide as part of that trial.
And there's no doubt that lifestyle is still the cornerstone, but it's one of these situations. We're not proposing that, that we need to have medications in these children, but when there are people who are saying to you, "I can't stop thinking about food," and when you're able to put them on something that allows them to feel in control, it makes a huge difference.
And final statement is that if you've got an adolescent that has such a degree of excess weight that it affects their mental health, they're bullied, they won't go to school, it's perpetuating that issue. So I think there's a real need in this area, yes, to look at the medications, but we're certainly not saying it's the whole story. Yeah.
All right, wonderful. Thank you very much to our panel of speakers and presenters today. Thank you for such an enriching presentation. Thank you to everyone who's joined us here in person and to everyone online. Enjoy your evening. Those online, when you exit the Zoom, there will be a survey come up. Please do take the time to complete that. And those in the room, please do complete the evaluation. Your feedback is really valuable to us, and we will be sharing it with the speakers today as well. So thank you and good evening. Thank you, Helen.